pituitary has an anterior and a posterior portion, and so some of the disorders are going to be reflective of a problem in the anterior section, in particular gigantism and acromegaly. That has to do with a growth hormone. So primarily, there's many hormones that come out of that anterior portion, but we're going to focus mostly on growth hormone. And then we'll talk about the posterior pituitary disorders, in particular, the disorders that stem from ADH, problems with antidiuretic hormone secretion. So we've got the syndrome of inappropriate antidiuretic hormone and diabetes insipidus. Okay, so familiar terms you've heard? All right, has anybody had a patient in clinical with any of these issues? Sometimes they come along with other things, or they might be a syndrome or something that's resulting from some other reason that they're in the hospital, and we're going to get into some of those topics. So it's not necessarily something they're admitted for right away. It might be something that's developed or something that is a chronic illness that they're dealing with. Okay, so just some orientation to the pituitary gland. We've got I mentioned earlier, the anterior portion in the front and the posterior in the back. So that purple area is the hormones that are secreted from the anterior pituitary, particularly growth hormone, which we're going to get into in just a minute. And we've got the adrenal, so it stimulates the adrenal cortex. We're going to talk about that next. So after we take a break and come back, I have another presentation to open up for you where we'll talk more specifically about adrenal hormones, the adrenocorticotropic hormone, ACTH, corticotropic, that's cortisol, so we're going to get deep into that. But it's initiating from the anterior pituitary, telling the adrenal cortex what to do. All right, and then we've got thyroid stimulating, we've got the gonadotropic hormones, follicle stimulating and luteinizing hormone, we've got the melanocyte stimulating hormone with skin, prolactin, and then we're getting into the posterior side, we've got oxytocin and antidiuretic hormone. We're going to get into antidiuretic today because the two pituitary hormones we're going to talk about are in the anterior portion, we're talking about growth hormone, and in the posterior portion, we're going to talk about antidiuretic hormone. So there's a lot. I wanted to show you this because pituitary does a lot. And it's right at the bottom part of your brain. In this previous picture, you can kind of see it's like right behind the eyes, right in the center, right below the hypothalamus. Okay, really difficult to get to. We talk about surgery for this particular organ because it does not look fun. How to get to it, right? Okay, so that's where our pituitary is in orientation with your head. And then there's this little, I guess, algorithm right here, or mnemonic. What's that? I can't remember the word. A flag pet. So it's just some cute, silly thing. Somebody came up, I did not come up with this one. I'll not take credit for it. But the O and the A are your hormones that are in the posterior pituitary. So oxytocin and the antidiuretic hormone. And then flag pet is all the other, the anterior pituitary hormones. So the follicle stimulating hormone, we've got luteinizing hormone, we've got, let's see, adrenocorticotropic hormone, growth hormone, prolactin, endorphins, which is not really on here, but that's the E part, and then T, what's left, thyroid stimulating hormone. Just something to help you maybe later on with NCLEX type stuff, but today we're talking about growth hormone, and we're going to talk about antidiuretic hormone. Okay? Reoriented maybe from your A&P courses. So pituitary does a lot. Once we get into some of those other organs, they're more specified on specific type of hormone. All right, so we're going to talk about hypopituitarism and hyperpituitarism. So hypo, so an underaction of the pituitary gland, right? This is rare. Usually we're dealing with a hyper, so an overactive pituitary for certain reasons. But when we're underactive here, it's a diminished secretion of one or more of those pituitary hormones. So signs and symptoms are going to depend on which particular hormone is being affected, right? Causes, I have it highlighted here. Tumor is usually the cause. Tumors can do the opposite too. Can be hypo or hyper, but in particular for hypo, a tumor might be the cause here. There could be congenital defects, something wrong with pituitary gland in birth and in utero, or trauma. Any kind of head trauma can cause an underaction, so it can damage the cells there and then they're not really functioning like they should. So that's some severe head trauma or swelling in the brain, increased intracranial pressure. Putting pressure on the pituitary can cause it to hypoact, could also cause hyper too. So we have to find out which is which by looking a little bit deeper into our diagnostics, okay? So panhypopituitarism is when the entire pituitary is affected. So that's a lot of catch up with all kinds of hormones we have to replace if somebody's not functioning in all areas. Okay, so some symptoms. So if we're looking at a hypofunctioning growth hormone, we're going to have delayed growth, right? So not enough growth hormone, we're not going to see a lot of growth. So we're going to see that maybe in some of those kids, watching them grow and they're not really reaching what they should be. Follicle stimulating or luteinizing hormone, that's amenorrhea, impotence, so sex hormones, so the lack thereof, so delayed in that menstrual cycle or releasing of eggs and fertilization, so difficulty getting pregnant, those kind of things can happen. Thyroid stimulating hormone, so we've got hypothyroidism, which we'll talk about on Wednesday. And then ACTH, the adrenocorticotropin hormone, or adrenal insufficiency. We're going to get into that later. So it starts in the pituitary and it signals the adrenals. Okay. All right, so how do we know we've got a problem that's causing a hypofunction in the pituitary gland? We've got CT and MRI, right? Because primarily we're going to have a tumor that's going to cause this problem. So we want to get in there and see, is that what's happening, right? Do we have a tumor and is it resting up right against that pituitary gland? We can check hormone levels, test for growth hormone, serum blood work, right? And then there's an adrenocorticotropin hormone stimulation test. Okay. All right, so with that stimulation test, what they can do is administer corticotropin or corticosteroids and see if there's a reaction in other hormones, so that they know if it's stemming from the pituitary, we won't see that function increase, or if we replace that hormone that's supposed to be initiating, we then see that function occur, and we can check those hormone levels after that organ's been stimulated. So it's a little bit complicated there, but they can kind of see where are we seeing the deficiency from. Is it originating from pituitary, where it's supposed to start with the ACTH, or is it something that's a problem with the adrenal gland? So again, we'll get into that a little bit later. There's lots of different things that we can do to check. So with hyperpituitarism, that's an overfunction of the pituitary gland, so we've got an increase of hormones, right? Symptoms, again, are going to depend on which particular hormone is being involved here, which part of the pituitary gland. So I mentioned trauma before and increased pressure, but sometimes that increased pressure on that pituitary can cause an increase in secretion of hormones, because we store some in the pituitary gland. So sometimes there can be an over secretion because of that. So compression of brain tissue, increased secretion of more hormones. So here we have another type of tumor, and it's highlighted a pituitary adenoma. It's a benign type tumor, so it's not cancerous, right? Or some tissue overgrowth. For some reason, that tissue is just growing out of control. Very similar to like a benign type tumor, just an overgrowth, but it could just be tissue related, not specific to a tumor. So if you've got compression of brain tissue, you might also have increased intracranial pressure. With that, you have a headache. There's a nausea center in your brain that can be triggered with increased pressure, so you can have nausea and vomiting. Increased growth hormone is going to cause what we call acromegaly, or gigantism in children. So again, we're going to talk about that. Arthralgia is like joint pain, kind of like arthritis. Just with that rapid growth, because it's affecting the growth plate in the adult stage, so there can be some joint pain there. And then the adrenocorticotropin hormone, that Cushing's disease. When we talk about adrenals later, this is why that's an issue if it's stemming from a problem with the pituitary gland. Right? So it can develop into a Cushing syndrome. And then we have increased thyroid disorders and, increased thyroid stimulating hormone. And then the increased prolactin, again, we're talking about depending on where the pituitary is affected, matters on which hormone might have problems with. So CT, MRI for a tumor, because that's the primary cause for this. I know they both kind of have the same. But we're going to get into a little bit more specifics when we talk about anterior and posterior. Okay. So everybody good so far? No? You just need to marinate it for a little bit, right? Let it soak in some. As we start splitting up the pituitary, like I said, anterior and posterior, we're talking about specific hormones like growth hormone or antidiuretic. Once you're kind of more comfortable and you repeat that information, it'll kind of stick with you after a while. So let's just move on and see if that helps. So anterior, front part of pituitary gland, okay? Remember that picture earlier? We were talking about all the different, there's a whole bunch of hormones that stem from the anterior portion of the pituitary, but we're going to talk about the growth hormone in particular. All right, so in childhood, increased growth hormone can result in gigantism. It's extremely rare, and you've seen a lot of people in movies. Do you remember Princess Bride? We're big fans of one of my favorite movies. It's inconceivable. Remember Andre the Giant? That's kind of was his nickname. I think, what's he called in that movie? I forget. But that's him right here. 80s movie. I'm a child from the 80s. This is a different movie. I don't think that's from Princess Bride. But in history, a lot of these folks were part of like circus sideshows because they were just so big, a giant man, and they got jobs that way and traveled the world and saw a whole bunch of things. But they were, in childhood, had this overgrowth or this excess production of growth hormone caused enormous growth. And so this is your average sized male, and then they're like super tall, right? Okay, so that's what's going on in childhood. And then we can have it in adulthood too. It can come about, and it's called acromegaly in adulthood. And so we've got a picture over here on the right that's got some of the symptoms that you'll see here. And then this video is a story. This guy Casey tells his story, and it's kind of a good way to hear it from somebody explaining it on their own. So we'll let that play out.
This is the truth. I was working with Corey's brother, and I saw this poster and said, I want to go out with your sister. My name is Casey McClellan. I'm 40 years old, and I was diagnosed with acromegaly in 2001. Sports has sort of always been what I've done. As an early infant, young kid, I always had a ball in my hand and started to naturally navigate toward team sports. And currently I referee college basketball and work for the Utah Summer Games. And so Corey and I were having a very normal, newlywed life. We were looking to start a family, and that wasn't working out how we'd hoped, and we're having a lot of difficulty. That's when Corey, my wife, was in dental hygiene school and started to study acromegaly.
We were just briefly learning about different diseases, different things that affect the jaw. As my professor was going along saying all these symptoms, signs and symptoms of acromegaly, I was just thinking in my head, oh my word, my husband has every one of those.
My jaw was starting to change. I had a bite that the mouth guard that I used at night was no longer fitting, which I thought I had bent it. And then my wedding ring was resized 2 different times.
So after when I went home, I said, Casey, I think you've got this disease, that you've got every symptom of this disease.
I thought she was nuts.
I did indeed make a doctor appointment for Casey to go get his blood work done.
But then when I went to my family doctor and told him Corey wants me to do my blood test for acromegaly, she wasn't crazy, she was spot on.
And I just looked back and said, told you so.
So 26 years old, the doctor basically diagnosed me with acromegaly, and he explained what the long-term diagnosis and treatment would be. I went from doing very little medication or none to being overwhelmed with, you're going to do multiple injections, medications to make you healthy. In the beginning, to be quite honest, it was a little overwhelming. But now, 15 years later, 14 years later, it's routine. It's something that I've put into my daily routine, and quite frankly, it's something that I don't really think twice about. So I actually do 2 injections. One is a subcutaneous needle, and my kids are very much involved with the process, whether it be helping me mix the injection, or the thing they really like to do is the alcohol swab, rub it on my leg, get ready for a little poke, and instead of being scared and worried about it, they really embraced it. I also do a monthly injection that is a 18 gauge needle, and there's a lot of anxiety leading up to that injection. I'm really fortunate that I've got a great wife who has medical training, being a dental hygienist, who's able to help me with those injections, but I'm not gonna lie to you, there's some anxiety leading up. Is this gonna be the night where it hits the muscle funny? Is it gonna bleed like crazy? With acromegaly, sports has taught me to be a fighter, and every day I get up and I'm excited that I get to have that day and compete, and acromegaly is not going to get me down. That's the athlete who I am, I guess.
Okay, so that's just his story, and it's good to see kind of like facial features are usually altered a little bit, or large spade-like shaped hands, they call it. Primarily the jaw and the brow ridge line and the hands are the places where you see the growth. So in adulthood, most of the growth has already been done, but then the growth plate starts to get affected again. So they usually have a lot of joint pain, kind of like adult growing pains in a sense. Whereas like with the gigantism, they super large because they've had their childhood while their growth plates were open and growing. So you see enormous growth happening when it starts in childhood. So yeah, it affects growth hormone. So hormone will affect all kinds of areas all throughout the body. So I'm mentioning the bones, the hands, the head, visual disturbances, hypertrophy of the sebaceous sweat glands. So all kinds of side effects there. And here's another story. This one is a picture of this was like the early 1900s. She used to be a nurse and got infected with acromegaly, and she was called the ugliest woman and ended up on the circus sideshows. I guess P.T. Barnum had her show up occasionally, and like this is an old picture, just how awful things were. Congress of Freaks and Ringling Brothers and Barnum. So it was, she was in this, and she ended up, her husband died young, so she had no other way to make money and joined the circus to pay for feeding her children, and that's how, went backwards. So that's how things worked for her. But you can see real prominent that larger jaw here and that brow ridge line, and this is before they probably realized what was going on. So isn't it nice that we kind of live in we do right now? All right. So some manifestations we've already talked about. So this is an overgrowth of the pituitary, causing growth hormone increases. So large hands and feet, large tongue, it can deepen their voice, so it affects the whole body here. Like I said, visual disturbances. This can cause an impaired insulin sensitivity. That's the serum IGF-1. It just causes excess insulin, and so it's kind of like having your blood sugar is spiked, and then your body just kind of gets used to it, so it's not as sensitive to it. So it's a little bit of an insulin resistance, very similar to like diabetes. Let's see. So there is an increased colon cancer risk. It's not really understood why, but they've noticed that that's something that comes along with this as well. Could be just an overgrowth of those particular type of cells, and then eventually develop into a type of cancer because of the just extra cells there, sometimes sitting around for a long period of time, can then become altered, like in a cancer. Cardiovascular complications, atherosclerosis and cardiomegaly, so enlargement of the heart muscle. So you can kind of see a cascade of things happening with this overgrowth of these tissues. So diagnosis, MRI, CT, this serum test to look at their insulin and their insulin sensitivity and those things. Oral glucose tolerance test, very much just like when you're testing for diabetes. So it's just, again, one result isn't going to paint the whole picture. They look at all the signs and symptoms and rule out tumor, hence the MRI and the CT scan. So all of these things together will help them to recognize, hey, we have an increased presence of growth hormone in their system, and that's how they diagnose it. Okay, and this pituitary adenoma, they can see on that CT also. Okay, so somatostatins, first line treatment, right? So these are gonna suppress that growth hormone. Octreotide is the generic that is typically given. Here's some of the brand names. Mycapssa is one. That might be what he was talking about, that you can give it a sub-Q injection or an IM injection. And I believe that one is the monthly injection, or you can have weekly sub-Q or daily injections or daily oral medications. They have an oral route as well. Again, you know, we're dealing with glucose altering, so hyperglycemia, hypoglycemia. So we need to monitor to make sure that we're not getting into dangerous levels with our blood sugar. Gallstones occur often in these patients on these medications. And some bradycardia, that's due to cardiomegaly. So we've got, it's enlarged heart, and now we're suppressing this growth hormone, so there could be some arrhythmias and cardiac misfiring going on there. So here's the treatment. Looks a little barbaric, huh? Radiation first is often what they're going to want to do, just to see if they can shrink it down, at least make it easier to operate on if they can shrink it down with some radiation. And then they'll go in and perform a transsphenoidal hypophysectomy. Yes, transsphenoidal meaning across the phenoid bone, right? Up into the nostrils. It's right behind the eyes. Okay, so there's an access point, and they can do this by endoscopy through the nares, and there's a video that follows, so you'll get to see a little bit of an animation of what it looks like. And then hormone therapy, of course, drugs to inhibit that growth hormone release, or growth hormone receptor blockers, and that's what that octreotide does. A little animation on this, because post-op care, so that's what I want you to be thinking about, is post-op care after somebody who's had this type of procedure.
The endoscopic endonasal approach provides a unique access to the ventral aspect of the skull base. The pituitary gland is located at the center of the skull base and is surrounded by critical neurovascular structures. Above the pituitary gland, we have the optic apparatus. On each side of the gland, we have the carotid arteries, which provide blood flow to the brain. And below the pituitary, we have the brainstem vascular artery. Tumors can arise from within the pituitary gland and then grow upwards to compress the optic apparatus, or they can grow to each side to invade the cavernous sinus. There are many other tumors that can arise in this area, above the pituitary gland, below, or inside the cavernous sinus. Here we can see a side view of the patient's head, and we can identify the location of the pituitary gland at the base of the skull and deep into the nasal cavity. Here we can zoom in and see the relationship of the pituitary gland with the sphenoid sinus, again at the deepest point of the sinonasal cavity and at the base of the skull. We are now going to simulate an endoscopic endonasal approach to the pituitary gland and the base of the skull. We use the nostrils as natural corridors to access the skull base. We can actually introduce instruments through each nostril, on one side the endoscope, and on the other side dissecting instruments such as micro scissors. With the collaboration of our ENT colleagues, we proceed with opening of the sphenoid sinus. This gives us access to the posterior wall of the sphenoid sinus, where we can identify the prominence of the pituitary gland, carotid arteries, cavernous sinus, and optic nerves. Here we can see the location of the endoscope inside the sphenoid sinus and the close-up view it provides. We use a high-speed drill to carefully remove the bone that covers the pituitary gland. We continue drilling laterally to perform a wide exposure into the anterior wall of the cavernous sinus on each side of the pituitary gland. We perform this Excel technique where very thin bone is left behind, so we can use a kerosene rainier to remove it safely and entirely. After the dura has been wide exposed, we perform our cruciate dural opening. We use micro scissors to open the dura in a cruciate fashion up to the level of the medial wall of the cavernous sinus. After widely opening the dura, we start identifying the difference between the pituitary gland, which looks well vascularized and more orange-like, from the pituitary tumor, which is less vascularized and more whitish or pale in appearance. By identifying this interface between both the pituitary gland and the tumor, we can develop an accurate plane of dissection to separate the tumor away from the pituitary gland. Whenever possible, we aim to perform an extracapsular dissection of the tumor to accurately separate it from the pituitary gland. In certain cases, tumors invade the medial wall of the cavernous sinus, and this poses a special challenge. For this, we have developed an original technique which consists in opening the anterior wall of the cavernous sinus to directly access the inside of the cavernous sinus and remove the medial wall. By directly opening the anterior wall of the cavernous sinus, we can identify the carotid artery in the cavernous sinus, the inferior hypophyseal artery running towards the posterior aspect of the pituitary gland, and we can gently separate the medial wall that contains tumor from the cavernous carotid artery. The medial wall of the cavernous sinus can be removed en bloc by performing the disconnection of the carotidoclinical ligament superiorly and the disconnection from the dural floor inferiorly. During this process, it is important to identify and typically coagulate and transect the inferior hypophyseal artery. At the end, we can achieve a complete tumor resection, including a complete removal of the medial wall of the cavernous sinus, which makes significant difference in patients' outcome, especially for functional pituitary tumors. As a conclusion, the endoscopic endonasal approach allows us to perform complete tumor removal with excellent preservation of the pituitary gland function secondary to the superior visualization provided by the endoscope.
Yeah, see how close he was to those carotids? That's the part that makes me nervous. Yes, and yes, your question?
So why did they have to cauterize and sever the?
It was perfusing to part of that dura that they removed, so there'd be bleeding, so they have to cauterize to keep the bleeding down. So interesting. I like the way he says pituitary. So, all that to say, it's really close to some really sensitive areas, like a carotid artery, so bleeding, obviously they would see any kind of immediate bleeding if there was a problem in surgery. But now, you've got exposure and some healing that needs to be done. So what they're gonna look like post-op is like they had a rhinoplasty, but except it's not. So they've got this packing for, the smaller blood vessels that have been cut, so potential bleeding that can occur there, and this mustache-like dressing. It's a little bit of facial swelling just with all the manipulation going on with the tools that are up in there, so the eyes are red and swollen. Okay, so thinking of intracranial pressure, right? So we're keeping their head of the bed up a little bit, so we're not increasing pressure to those areas because we don't want to initiate any bleeding or put any extra pressure in that area with some fluid, all the inflammation going on post-operatively. So strict eyes and nose, because if we're removing part of pituitary gland here because of a tumor, there could be a change in hormones. And so when we get to the antidiuretic type hormone, we might be watching for some of the syndromes that can occur with too much or too little of that particular hormone. So we're concerned about urinary output and fluid overload when it comes to those. So strict eyes and nose is going to be part of your care. We're going to be looking for vision changes, pupil response, any of those issues. No nose blowing, right? That's increased pressure. You can cause severe bleeding if we allow that. No nose blowing, sneezing, or vigorous coughing for a minimum of 48 hours. Right? Just to allow some of that initial healing in those blood vessels so we're not causing some bleeding to occur. Yeah.
How do you stop them from sneezing?
I don't know how you stop someone from sneezing. So they've got packing in there, so usually that's not going to really stimulate any kind of like tickle sensation like allergies would. There's all kinds of stuff going on up in there, so that may suppress it. But yeah, no vigorous coughing. They might need to clear their throat a little bit, but we don't want to do any hard coughing. So encouraging deep breathing, that helps keep everything open, so you're not getting any extra fluid on their lungs, so then they don't have to cough, right? So some nice deep breathing, keeping things flowing, keeping the lungs clear of any fluid. No straining for bowel movements, right? That causes increased pressure. Let's see. So in this picture here, this is what a dressing might look like if it had that halo appearance. That would be the presence of a cerebrospinal fluid leak. So just because of where it is in the brain, we want to make sure that there wasn't some kind of entry where we could have a leakage of fluid. And so CSF fluid is clear, but in a dressing here, after it's been mixed with blood, we have like a yellow halo appearance. So you'll see the blood in the middle, and then you've got that kind of yellowish sign on the outside. Let's see. Oh, and glucose would be present in it, glucose and protein from your CSF, so the dressing can be tested for that. So gentle mouth care, soft toothbrush. But initially, we're gonna hold off on any of that, and that's because they may, instead of going through the nose, they may go through the palate. So in that case, we would want to avoid toothbrushing at that point. Monitor for signs of bleeding, obviously. Okay? So what's your priority? We're watching for, we want to prevent bleeding post-operatively, right? So, and increased intracranial pressure. So if a good portion of the pituitary has been removed, there's likely going to be some hormone replacement, right? Because it's stemming from our pituitary gland. So lifelong hormone replacement is going to be needed, so we really need to help our patients understand they need to be taking these medications, they cannot miss them. Their brain is no longer producing that for them, so they need to give it exogenously, so they need to take those medications. And then if it's affecting fertility, of course there's education that goes on there, so depending on what hormones might be involved, is going to require some teaching. Okay, so we got anterior and growth hormone, right? Because that's the area of the brain where that in particular is affected, and we'll talk about thyroid later. Okay, let's talk about posterior pituitary and our antidiuretic hormone. Okay, so to pee or not to pee? That is the question. So we have syndrome of inappropriate antidiuretic hormone, and I know we've talked about that very, very briefly in the past, right? It's been mentioned. And then diabetes insipidus. So you've got your soaked inside and your dry inside. SI and DI. And it's just some memory joggers and some pictures to help you think through that. So backing up a little bit, we're talking about antidiuretic hormone. So antidiuretic, the opposite of diuresis. So holding on to fluid. And this hormone is going to tell our kidneys to hold on to sodium, which makes us hold on to water, and it also makes us get rid of potassium. Okay. This hormone is also called vasopressin, so we can give an artificial vasopressin if we need to replace this for somebody, but that's jumping too far ahead. But just know vasopressin is the same thing as antidiuretic hormone. So the pituitary stores and releases this antidiuretic hormone. It's initiated in the hypothalamus and sends it to the pituitary where it can be stored, and then the pituitary is responsible for releasing it when it's needed. Okay? So again, sodium is retained and potassium is secreted by the kidneys. That's what this hormone is doing. Okay, so whatever our pituitary says to the kidneys sends ADH, the kidney takes care of it. So if it's sending a lot of ADH, we're going to hold on to a lot of sodium and therefore water. And if we're not sending ADH, then the body is going to be releasing a bunch of sodium and water. Okay? So far so good? What does ADH do? Antidiuretic hormone tells the kidneys to do what? To hold on to water by retaining sodium, right? Okay? Alright, syndrome of inappropriate antidiuretic hormone. Soaked inside, right? So inappropriate antidiuretic or increased antidiuretic, if you want to think of it that way. But it's inappropriate, meaning we've got too much of it. So then the body's holding on to way too much water. And this happens pretty quickly, rapid weight gain from that water. Okay? So when thinking back to your fluid and electrolytes, right? If we've got a lot of water, and we're holding on to a lot of water, what is that doing to our osmolality? What is that doing to our sodium? Hypo, right? So we're seeing hyponatremia. It's not a loss of sodium necessarily. It's just diluted hyponatremia. So because of all the extra water, we don't have a lot of solutes in in our fluid, right? So our serum or our plasma osmolality is dilute, decreased. So sodium and osmolality are down. Whatever urine we are excreting is going to be concentrated. So the osmolality of the urine is up. Because it's not a lot of water in there, but we're still going to excrete some things, so it's going to be pretty concentrated. So you kind of have to stop and really think about these things. This is where you've got your opposites going. Some things are up, some things are down. So if you start with what antidiuretic hormone is doing, it's making us retain water, holding on to that sodium, which the water is going to keep following, right? So we're diluting our blood. So if we got a lot of fluid floating around in our vasculature, what's that do to our blood pressure?
Raises it.
Yep, raises it up, turning the faucet on the hose, right? Turning it up, putting extra water in there, creates a lot of pressure. So we're having increased blood pressure. On this picture is talking about seizures too. That's because of the diluted sodium, that hyponatremia, right? So what's causing it? Typically, small cell lung cancer is actually, so this is sometimes a sign that's seen and how they know to look for small cell lung cancer. Because the lungs can create like a hormone that's very similar to an antidiuretic hormone and cause an increase. So other issues, CNS disorders, trauma, stroke, brain tumors. It's causing pressure against that pituitary, and that's on the posterior side, so it's going to cause more of that ADH to be secreted. So ADH goes up too high, and now we have syndrome of inappropriate antidiuretic. Some infections can do that. Again, that's increased inflammation and increased pressure on the back of the pituitary, causing extra excretion of ADH. Okay? So other pulmonary disorders, lung abscess, TB, pneumonia, because of that hormone that's released from the lungs that's very similar to ADH and causes a diuretic type effect. There are some medications that will stimulate ADH release. Some of these are to treat the opposite problem that we can have with too little ADH, and we can swing somebody the opposite direction. We're going to talk about some of these. This isn't really for memorizing. We're going to talk about meds that we use to treat these particular disorders. Just know that some other medications can cause an SIADH to occur. Okay, so signs and symptoms. So if you stop and think about it, right, you could probably think of a few without even looking on the screen, right? So if we have too much antidiuretic hormone, what's the first thing that's going to happen? Too much fluid. Yeah. Increased weight, yeah. So increased intravascular fluid volume and weight gain. We already talked about blood pressure. So if your blood pressure is up, your heart rate's going up, try to compensate, try to get some of that fluid off. And we talk about decreased urine output, because if everything's gonna stay up in your vasculature, your kidneys don't wanna let go of that fluid, you're not gonna pee a lot of fluid out, right? So the osmolality of your urine or your specific gravity is gonna go up. It's because it's concentrated, okay? But your serum osmolality, so that's how much solute, how dilute your blood is, that's gonna go down. Because it's a whole bunch of water in there, not a lot of stuff. Everybody good? Following? Trying to go slow, let it marinate. A lot of ups and downs, okay? So hyponatremia, again, I'm kind of repeating myself here, but you need to hear it a couple of times. Too much water dilutes what sodium we had, right? So we're holding on to that sodium, we're not getting rid of it, but because there's so much water, it's diluting that sodium. So if we let this go too long, we've got extra water, cerebral edema, right? And neurosymptoms, confusion, lethargy, seizures, and coma if it gets really bad, okay? So we got thirst early, fatigue, shortness of breath on exertion, we got excess fluid, right? Fluid buildup, muscle cramps, it's the electrolyte imbalance that's going on here, right? So we're seeing like a hypo in our electrolytes. And headaches, okay. And too much ADH. This was just talking about sodium in the brain, the normotremia, and the acute hyponatremia. Think neuro. We've talked about this before. NA is neuro, K is cardiac. Okay. So what do we do? On the left side, I have it bolded because it's going to be the same for anybody with ADH, with problems with antidiuretic hormone, right? So we want to know their weight, whether we've got too much or too little. Right? We want to know where that fluid balance is going. So if we have a change greater than 2 pounds in 24 hours, that's something to note, right? That's too quick to have a weight gain. That's a water shifting. That's either too much water we've gotten rid of. So 2 pounds in 24 hours, we'll notify the provider. Obviously strict I's and O's, right? If we're talking about water and where the water is, and if we've got too much water, we're going to have a fluid restriction, right? An example, like even down to 250 to 500 mils in a 24-hour period, right? So just sips with their meds, not a lot of fluid. Usually they don't have much of an appetite either because they're just so fluid overloaded. It's pushing up on our organs and stomach and just no appetite. Safety, seizure precautions. Why? Hyponatremia, right? We just talked about that. And vital signs, because we've got extra fluid. So what might we see? Hypertension, tachycardia, maybe even some hyperpnea, whatever you call it. Breathing fast. Right? Okay, so some other things specific to SIADH, we've got loop diuretics, right? Now what do we have to watch out for though? If we're giving a loop diuretic, hypokalemia, because we're already kind of getting rid of the potassium too. So they might put them on a loop diuretic and add potassium supplement, right? Okay, making sense? Why normal saline?
Okay, yeah, why are we?
Say it again?
Replace the sodium.
Replace the sodium. So we're not giving huge boluses, right? This is an isotonic fluid, but it's really for the sodium replacement. There's probably other ways we could do sodium here, but same with the hypertonic saline. That's if we have extreme, so there's your hint right there. Extreme hyponatremia, we're gonna have more concentrated hypertonic type solution if needed, right? So that might be in somebody who's already had some severe neuro changes. Yes? Thiazide would work, but you don't release as much water as you do from a loop diuretic. So it's where more water gets reabsorbed in the loop of Henle than in the TCA portion of it, of the tubules in the renal and the kidneys. So we get a lot more fluid out. So we've got a ton of fluid on them. We want something that's gonna work really good to get a lot of water off. So, but we can chase our tail with that and add potassium, knowing that they're probably gonna waste some. So we have to watch their labs, right? We wanna watch it anyway, sodium and potassium. And we're gonna be probably replacing with some potassium supplements too. They just work better. Everybody gets Lasix, right? Isn't that our go-to? Until it's a problem, and then we go to a thiazide diuretic. Or maybe it's somebody who we really don't need to pull a lot of fluid off, and we'll go right to thiazide in that case. Different situation here. So, the med I want you to be aware of is daclomycin. This is a tetracycline type antibiotic, confusing, but it acts to inhibit ADH. It's just some extra thing that it can do, right? So they give this because it works so well to inhibit ADH. So it promotes diuresis. And the other piece to watch here is we don't want to have them take it with milk or avoid calcium while you're taking because it's going to impair the absorption of that medication. So daclomycin. Got it? Okay. Diabetes insipidus. So now we're going to swing the other way. Yes. Just because it says diabetes doesn't mean we're really talking about blood sugar here. Okay? We're talking about antidiuretic hormone. Dry inside, so not enough ADH, right? Deficiency, or it could be because of a problem in the pituitary or a decreased renal response to it. So that's where we can do some stuff with some diagnostics to determine, what's the cause? Is it pituitary, or is it having to do with the kidneys just not recognizing ADH? Like in a renal failure type situation. Okay, so this leads to urinary output and fluid electrolyte imbalance. So if we are getting rid of too much water, we're not seeing antidiuretic hormones, so the kidneys are like, let's just keep going, let's get this water out, that's our job, that's what we do until it says, whoa, hold on, right? So we're releasing all this fluid. It's leaving sodium behind, right? In our blood. So let's look at some of these. Actually, let me back up a little bit. There are different types or different causes. So it can come, like I was mentioning before, a central type diabetes insipidus. And I have this arginine vasopressin deficiency up here. That's actually the new term for diabetes insipidus. I know, they're changing the terms. Everybody's still calling it diabetes insipidus, central diabetes insipidus, or renal diabetes insipidus. But it's helpful for you to know that if it's coming from the problem in the brain with the tumor, problem with ADH synthesis or release, then it's a deficiency, right? But if it's the kidneys, it's a resistance to it, to this ADH hormone, this vasopressin, right? So there's a lot of different terms to say the same thing. But what you really need to know is, where is the problem stemming from? Is it a central problem, a neurologic problem? So either the hypothalamus isn't telling the pituitary, or the pituitary isn't releasing appropriately. That is considered central. So think central nervous system, CNS, central diabetes insipidus. You're probably not going to see the arginine vasopressin deficiency term. Just in your future, you might hear that more. But no, it's the same as diabetes insipidus. So it's a deficiency in the hormone when it comes from the brain or the pituitary, right? When it's renal, brain and pituitary are, hypothalamus, pituitary are doing just fine, sending the signal down, but the kidneys aren't recognizing it. So it's a resistance at that point. Inadequate renal response to ADH. So kidney damage or certain medications will do that. Make sense so far? I know it's a lot of terms, but brain damage or tumor is a central diabetes insipidus problem. Kidney's not responding to the hormone. is either because of medications or some kind of kidney damage or trauma to the kidneys. There is a gestational one, happens in the 3rd trimester, has to do with the placenta and an enzyme, the vasopressinase, which really just kind of breaks down the ADH. It's resolved after delivery, usually takes a couple weeks, body recovers from it. Not really gonna get into that, just kind of an FYI. I don't know if you guys talked about it in OB, or if that was TMI at that point. You had enough to cover in that class. But just know it can happen there. So it gets overlooked because, especially in the 3rd trimester, baby's sitting on a bladder, woman has to pee a lot already. So sometimes it's not even recognized, but it can happen. Okay, so instead of holding on to water, we're releasing water. So this is probably where it got the diabetes connection, is in the polyuria and polydipsia, but it's not a glucose issue, it's an ADH issue. So these people are like 2 to up to 20 liters per day, or 24, it can go higher than that. Your book says 2 to 20. 2 liters per day isn't so bad. A lot of people are kind of, that's normal, unless there's somebody who doesn't really take in a lot anyway. But, you know, once they're getting up to 4 or 5, 6 liters, or 20 something liters, you're constantly peeing. So because you're getting rid of this fluid, you're not leaving much to your tissues. You're gonna have dry mucous membranes, poor skin turgor, signs and symptoms of dehydration. So we don't have a lot of fluid in our blood, in our veins, and our arteries. So what's that do to our blood pressure? Drop it. You guys have covered this before, right? Hypovolemia, hypotension. Tachycardia, heart's gonna try to catch up, right? So compensation's happening there. It's like, oh, we've got lower volume, so we gotta send these cells around a lot faster now to get that oxygen going, try to get fluid wherever it can get it to. So heart's gonna go up. Nocturia. I mean, if you've got 24 liters your body's trying to get off of you, you're gonna be up peeing all night, so that's what that is. And you're gonna be tired. One, because you're constantly up peeing and you're not getting enough sleep, but also you've got some electrolyte imbalance too going on, right? And dehydration. So what are your labs gonna show? So if we have a whole lot of urine output, a lot of water coming out, it's gonna be very dilute urine, not a lot of solutes. So below urine specific gravity, less than 1.005, or at low osmolality. Same thing, just 2 different lab results. So decreased water in your veins means you have more solutes. So you're gonna have hypernatremia, right? And your serum osmolality, your concentration in your blood, is gonna be up. Not a lot of water in there, it's gonna be concentrated, lots of solutes. Got it? Is it starting to kind of clear up a little bit?
So it's like the opposite of
That's the opposite of SIADH.
I thought SIDDH, or whatever it is, mixed up with HHK, because you know how it used to be SAIDHK. I got them mixed up with HHK, so I was like, oh
I
yeah,
know.
so it's just dehydration. Whatever your
I read the wrong chapter. All right. So too little anti-diuretic hormone. We're diuresing too much water, leaving our body. So urinary output's going to be a big sign that this could be going on, right? One of our first signs. Specific gravity is low. Again, we got to look at big picture here. Look at everything that's going on. Specific gravity that's really low could just be a really well hydrated person, but we've got all these other things going on. So we can do this water deprivation test. So it's exactly what it said, we're gonna NPO, no water, right? And we'll get a morning weight and labs. We're gonna check a baseline serum osmolality, right? Or specific gravity, could go either way. And then they're gonna check the urine hourly while they're holding off on hydration. So we're causing a dehydration even further, right? But they'll stop when they get to like this orthostatic hypotension point, because now we're having orthostatic hypotension, and postural tachycardia, so heart rate's elevating as they get up. So it's like, okay, let's stop here, because now we have this response, right? So we know we're getting to a point that's not safe. They might also have a 5% body weight loss, so that's fluid loss, right? Additional fluid loss. Urine concentration does not increase. So once they get to that point and they decide, okay, we're gonna stop holding off water, we're gonna give desmopressin, this medication, DDAVP is a brand name. And then they're gonna check the urine osmolality again in an hour. So what's supposed to happen is it's supposed to be able to concentrate the urine. So response is central diabetes insipidus if an increase in osmolality. So they can't concentrate it. Renal diabetes insipidus if there's no change to it, right? So they know if it's coming, if it's central or renal at that point. So once they know which is which, if it's central, we're gonna go ahead and give some fluids, replace those fluids, and we're gonna do that desmopressin. So it's basically like a synthetic vasopressin. So we're gonna resupply them with the hormone. You can give it IM, PO, or intranasal. And so there's this chlorpropamide with a thiazide diuretic. That's a diabetic medication. It's actually off the market. I just saw that in searching for updates on this. So it's not even anything that we have in the US anymore. But it was working to go ahead and stimulate this it acted like a antidiuretic hormone, along with this thiazide diuretic. It was really confusing, so I was looking for articles to help explain that, and we don't even have that medication anymore. That's what I was telling you about. So desmopressin is the primary, that's typically what they're gonna give. So that's the common one. So if it's renal, we're gonna limit their salt to less than 3 grams, so sodium restriction. The thiazide diuretics are gonna help because it's not gonna release too much water. What's happening here is it's gonna reabsorb that sodium in that distal convoluted tubule. So we were just talking about loop diuretics versus thiazide diuretics. So that's why they're gonna use this one. It's not so much because we can replace that fluid loss by using the diuretic, but it's mostly about that reabsorption of that sodium. Right, so we wanna keep some sodium to get that water back into our bloodstream. Okay, does that make sense? So we've swung the other way here. We're getting rid of too much water. We want to hold on to water. So if we can trick our body to holding on to water by holding on to sodium, this thiazide diuretic can do that. So yes, we're going to lose a little water, but it's that sodium that's going to try to help retain some of it. So I know it seems counterintuitive to you to think about a diuretic when we're already losing water, but it's about that sodium that we can hold on to. So NSAIDs will help reduce that urine volume, so it slow down that loss. So that's just another effect that we can have by giving that. So sometimes they give a combination of different medications to help in more than one way to hold on to water, okay? So left side's pretty much the same as the last time. Daily weight, strict eyes and nose, and we gotta worry about safety. This time with the strict eyes and nose, we're gonna restrict fluids that have a diuretic type effect, that cause us to go, or caffeine. Certain fruits have a diuretic effect, like watermelon and grapes. IV therapy, electrolyte replacement, and oral hydration, right? I always wanna go oral first if we can, but if we need to really replace it quickly, we can do an IV therapy. And safety, like fall precautions, so our sodium's out of whack. We've got some issues there. Or if they're up and voiding a lot, and they're older, that's getting up and out of bed a lot, so fall precautions are part of our safety there. We had seizure precautions on the other one with the hyponatremia. Okay, so on the other side, we've got vital signs, CVP, central venous pressure, something, it depends on if they're in intensive care unit, and we can monitor those pressures. And labs, we're gonna assess their hydration status, so mucous membrane, skin turgor, dehydration, constipation, we will monitor that. If we don't have any fluid, our stools are gonna get harder. So we want bulky foods like increased fiber, laxative may be needed. Monitor for water intoxication, right? Headache, confusion, because we could be swinging the other way too. And of course, caffeine, avoid caffeine. Okay. So we're right at 2:05, we're gonna take a break. So that's your SIADH